Hi, welcome to the 12th Annual St. John's Breast Symposium. I'm so glad that you were able to join us this morning. As you know, this is an event that over the last 11 years has grown from a small gathering of 30 people to 300 people. We had our first virtual symposium last year, and we were really hoping to have an in-person meeting this year, but this recent COVID surge had other plans for us. But we still wanted to have an event to mark this 12th year that was bigger than our last. And we also decided to take advantage of the fact that we're virtual, and I think you're going to see some great footage from our speakers in places we normally wouldn't see if we had been in person at the Sarah Center. I do want to thank the team for all of the work to get this event to happen despite those last-minute changes to a virtual presentation. And I'm so very excited about the panelists that we have today. Each of our speakers today will give a short presentation about the idea of moving forward, and then we will follow with a question-answer period just like we do in person. Please put your questions in the chat box in the Zoom window. You might have to look at the bottom of your screen, and if you don't have a chat button, look for 3 dots and a chat option should appear. And when you do, click on that chat box and it should appear on the side of your screen. Then type your questions there, and we're going to try to get to as many of them as possible when we finish the panelists at the end. And just as we do in person, during our question and answer period, we'll also invite any other physicians in the audience on screen to help participate in the question and answer session. So this year's theme is moving forward. And the team thought that this was such a fitting theme for this year's symposium. For the last 17 months, our worlds have been turned upside down in so many ways. And at the time we were planning this symposium, it felt like we could see the light at the end of the tunnel as we started to emerge from our homes and tried to find that new normal. Moving forward to us also talks about the people who went through or are going through treatment and looking toward the point when they can rebuild their lives. And finally, moving forward also talks about the new technologies, the new techniques and treatments and new ideas about breast cancer treatment and overall breast health. So I hope that you will join me today as we explore moving forward together. Now at Dignity Health, we usually start every gathering or meeting with a reflection. And today I'm so happy to have the Reverend Kate Lewis give our reflection.
Good morning. I'm Kate Lewis. I'm the manager for spiritual care at St. John's Hospitals in Oxnard and Camarillo, and I am pleased to be welcomed into your community. Because I'm not a person who's lived with cancer. I'm not a person who's directly cared for a person living with cancer. I'm a chaplain and I'm a priest. I am one who honors and listens. And I've heard that this is a journey that no one asks to be sent on. I have heard that this journey is hard. And I've heard that this journey can awaken sleeping spirits. And I have heard that this journey ultimately is about the human capacity for love. And so I honor you, and I stand in witness to your effort and your hope. My spiritual teacher is the Right Reverend Stephen Charleston. He's an elder among the Choctaw people and an Episcopal bishop, having served in Navajo land and Alaska. He rises before the sun each morning and prays with the earth and the spirit and the ancestors, and he shares those prayers with thousands of followers on Facebook. To set the tone for your day today, I'm bringing you 2 of his posts, and I invite you to hear them as the word of our elders. Hear them with authority, as the words of the wise ones who are close to the Spirit. He writes, "You are a beautiful soul. Always remember that. No matter what happens, win or lose, up or down, however your life may be at this moment, never forget that at the center of it all is something that will always be the same, always be secure and inviolate, the soul that is uniquely you and will be forever. Serene, steady, a connection to a higher power that cannot be broken. You are a beautiful soul. Always remember that. Count on it. Depend on it. Because you are not alive by accident, but by the design of love, for the purpose of blessing and the intention of healing. You are all these things and so much more because you are a part of eternity, a precious spirit at sail on the sea of life, under the watchful care of the one who made you. Always remember that, and the rest will unfold as it was meant to be. And here is the second of his meditations. He writes, "Out praying in the summer evening, the heat comes off the ground and it holds me to the earth. The sky turns purple and streaks of yellow and orange stain the western edge of the world. The air barely moves. The first stars, lazy in the heat, make a reluctant appearance, while the moon keeps watch without ever-changing expression. I feel a sense of great peace, a reassurance given without hesitation, a promise made by a heart that has never known deceit, a blessing ordained with a touch that heals. And the answer to my prayer is a message for everyone. Do not be anxious or afraid. Do not feel alone or forgotten. Do not doubt or despair. The Spirit is with you. You will feel the sacred enfold you. You will be renewed in the vision that has guided you. You will discover a path you need, and the sources of your support will both surprise and comfort you." A message given and received on a still summer evening. So with these words from our elders, I commend to you a beautiful time together today of moving forward in hope, peace, and love.
Thank you, Reverend Kate, for that wonderful reflection. Next, we have Darren Lee, who is our hospital and president of St. John's Hospital. Give us a welcome.
Good morning, and welcome to our 12th annual Breast Symposium here at St. John's Regional Medical Center and St. John's Hospital Camarillo. What a wonderful time it is to come together. This not only is our 12th annual symposium, but is the celebration of the 25th anniversary of our cancer center right here at St. John's. This past year has been difficult for everyone. We've fought with COVID-19 throughout our community and throughout the world, but that doesn't mean we have stopped. At St. John's, we have continued to move forward, and moving forward is the theme of this year's symposium. At St. John's, we opened up our brand new emergency room, which doubles the square footage. We include X-ray right in our emergency room so that we can provide the services even quicker and more efficiently than we have before. We've also designated some space within our emergency department to care for those who are challenged with mental health issues. In addition, we have opened our maternity center. No longer do women need to come through our emergency department when they are giving birth or have issues with delivery or labor. Instead, we have a separate private entrance that's open 24/7 so they can go right into our labor and delivery area, which is located right next to our relatively new NICU, which houses 20 private rooms for our infants who need specialized care. In those rooms, mother, father, or a loved one can actually spend the night with the baby in our NICU. We have a family room where they can shower and has a kitchenette, and they can take care of their needs while they stay in the hospital with the infant. What a wonderful time for us to continue moving forward, which again is our theme for this year's symposium. We have many, many great speakers lined up for you today who will not only provide information and resources for you personally and resources that you can share with a loved one who may be struggling with cancer in your family. They will be here to provide education, inspiration, and a vision for you so you can work through these difficult issues. Please take the time to listen to the speakers, take advantage of the resources that we're providing for you today, and enjoy your time with us. Thank you for joining.
Thank you, Darren. You've always been so supportive, not only of our program, but of this symposium. Next, we're going to hear from Harriet Friedman. She is one of our patient advocates. She's always been so involved with our Integrated Breast Center, and she's going to talk about her experiences, her journey, and the role that the Integrated Breast Center played for her.
I love this center. They've saved my life, basically. I've had cancer 3 times, had major surgery each time, and the doctors here saved my life. They knew just when to diagnose and just when to do everything to help me through it. Dr. Jeffers is an amazing woman, and what she's done here to establish this center in all that she's done and been through, I just think she's a miracle lady. And I was told way back when I would someday have breast cancer when I was a girl. The doctor said I had a lot of high-risk issues. The first lumpectomy I had, I was 15 years old, and it was benign, but I had 7 of them. And then I moved here and I went into a clinical trial with Dr. McIntyre, who of course has since retired. She put me on tamoxifen for 5 years. Within 6 months after I stopped taking it, I had the first cancer, which I had removed, and I had radiation, and I had quite a few lymph nodes removed. Then I was put on Arimidex for 5 years. Shortly after I came off that, they found the second breast cancer. And I wound up having a double mastectomy, and Dr. Jeffers took over a year to do the reconstruction surgery, and thank God I'm fine. But the main thing that's so important is once you've had cancer, you can never forget that you've had it. You have to follow through. And they had me at first after each surgery. Every 3 months I went for a PET scan or an ultrasound or whatever the doctor ordered at that time. Gradually it moved up to 6 months, and then it was 9 months, and that's when they found the next cancer each time. The third cancer I had was found by my cardiologist. He was going to do a procedure, and I had to have a scan, and they found a spot. He thought I had a heart blockage, but it turned out I had lung cancer. Had part of my lung removed with 2 huge tumors, malignant tumors in it, but no treatment since I don't do well on medication. And thank God I'm fine. I'm doing okay. It's 3 years since I had the lung cancer, and I'm okay. And I thank the people here because everyone has helped me get through it. And I think the important lesson for all of you people that have had cancer, particularly breast cancer, don't let go of it. Follow through. When the doctor says you go every so many months to have a check, you do it. Unfortunately, I have 2 dear friends that died because after the first year, they said, well, there was nothing there anymore, so why bother? And they died a year later after that. It spread. And that's really unnecessary deaths that fast. So I guess my big point is to just keep moving forward and take care of yourself. Listen to the people here, and everybody here is amazing. Alicia, you've helped me so many times in so many ways to get through to the doctor, or to get through to find out what's wrong, or whatever I've ever asked you, you've been there. I have to mention Diane, who leads our breast cancer support group. She is an amazing woman, and she has helped us all. I'm one of the original members of the group, and I still go. A lot of them have dropped out since the pandemic, but I still go to it all the time. I try to on Zoom. And the other person I really like working with is Susan. I didn't have good reactions to the stress and the medication, and I went on different food plans, and Susan helped me through it all. And some of them were pretty crazy, but they worked, and she's amazing to work with. So I encourage everybody that's listening today to keep in touch with this cancer center. Listen to them, ask them questions, but let them help you get through this. It's very important. You have a support system. I know I made it, and I'm tough, but I still couldn't have done it without all this help.
Thanks, Harriet. Thanks for always being such a great supporter of our program. And next we have Dr. Deborah Abelson. She is a radiologist and she'll be talking about updates in breast MRI.
Hello, my name is Deborah Abelson and I'm a breast imager with Rolling Oaks Radiology. Thank you for having me here today. I'm going to talk about tomosynthesis, also known as 3D mammogram. I will talk about what tomosynthesis is, who should get one, and what its benefits and limitations are. Here's an example of a tomosynthesis unit. So tomosynthesis is a 3D mammogram. It's an FDA-approved advanced technology that takes multiple x-rays of the breast from different angles to create a 3D picture. Traditional or 2D mammography obtains single images of the breast. Here's an example of a 2D mammogram. The breast is compressed and a single image is taken. You can see the purple irregular area is an abnormality in the breast. In the mammogram image on the right, that purple area is obscured or covered by the blue dots, which represent normal breast tissue. That is one of the main limitations of 2D mammography, that normal overlapping tissue can hide abnormalities. In tomosynthesis or 3D mammography, multiple images are taken of the breast, and we look through the breast tissue slice by slice, kind of like going through the pages of a book. This allows us to see abnormalities more clearly. Who should get tomosynthesis? Anyone who needs breast screening, has any breast symptoms like a lump or pain, or needs additional testing after, or who needs additional evaluation for something seen on a screening mammogram. Also anyone who has dense breast tissue, has a higher risk of developing breast cancer, or is getting their first or baseline mammogram. Breast imagers categorize breasts into 4 different densities, which you see here labeled A through D. A is the least dense breast, and D is the most dense breast. Density refers to the milk-producing tissue in the breast. This tissue shows up as white on a mammogram, and as you can see, the most dense breast, breast D, is the most white of all the mammogram samples here. Unfortunately, many abnormalities and cancers are also white on mammogram, and therefore they're more easily able to hide in a dense breast. Some of the benefits of tomosynthesis over 2D mammography are it detects more cancers, especially in dense breasts. It detects cancers when they're smaller and therefore more treatable. And because it allows us to evaluate the breast tissue more thoroughly, it decreases the chance of having to come back for more testing after a mammogram. Some of the limitations of tomosynthesis it is not available at all medical facilities. Only about half of MQSA certified mammography facilities in this country offer tomosynthesis. It also may be more expensive than 2D mammogram, although insurance coverage is increasing as the technology becomes more widely adopted. What to expect during a tomosynthesis exam? It should feel very similar to a 2D mammogram. The only difference is that in a 3D mammogram, the X-ray tube travels in a short arc over the breast, so it takes a few seconds longer. Surprisingly, the radiation dose in 3D and 2D mammography is about the same. Even though more pictures are taken during a 3D mammogram, those pictures are much lower dose than those taken in a 2D mammogram. So at the end, the radiation dose is about equivalent. And I would like to end with this motto: early detection saves lives, especially as we enter October, which is Breast Cancer Awareness Month.
Thank you, Dr. Abelson. Now next we have Dr. Lisa Babashoff, very familiar to any of you who've been here before. She has spoken since our very first breast symposium, and today she's going to be talking about new tools in breast surgery.
Hello, my name is Lisa Babashoff. I'm a general surgeon here in Ventura County. I've been in this county for over 21 years, and I have a special focus on breast surgery. I deal with a lot of breast cancer around the area, and I'm here today to talk about new tools in breast surgery. I'm going to focus on 2 of the new techniques and instruments that we have in the operating room here at St. John's. I'm first going to talk about newer techniques in breast localization. So the standard of care over the years for when someone comes in with a small breast cancer is to do a lumpectomy. Most of these tumors I can't easily feel, so I need some sort of a localizing device to be able to know in the operating room where exactly the tumor is. Traditionally, this was done by needle localization. That is having a woman have a wire put into her breast, into the area of concern before the procedure, so that I can use that wire as a guide in surgery to tell me exactly where the tumor is that I need to take out. The disadvantages of this, it can be a painful procedure, and it's required to be done on the same day as surgery, so that these women have to come in usually a few hours before, or 3 to 4 hours before their actual surgery, to get the wire placed. So it's more of a time commitment on the same day of surgery. And it's also not possible in certain cases. Patients that have small breasts or that have implants may not be a candidate to have the needle localization. Okay, so this is showing an example of what is done when you have a needle localization. So this is done by the radiologist, and as you can see, a needle's poked into the breast and a wire is thread through this needle that is used for the localizing device. As you can see, this isn't always very comfortable. This is an X-ray image of a needle localization, so you can see the wire is coming into the breast and it's going to the outside of the breast tissue. This is what I see at surgery. So the needle localization has been the standard of care for years and years. More recently, we have obtained what's called the Savvy Scout system here at St. John's. And as you can see from this image, basically a clip is put into the breast in the area of concern, the area of the tumor, and this clip works by radar, so that when the patient comes into the operating room, I can use a probe that's a handheld probe to localize the area of where the tumor is. So there's many advantages to this technique. One is that the clip can be put in any time. It's not put in the day of surgery, so that there is not such a time commitment involved in this. It can be put in years before, although that wouldn't usually happen. And then the patient will come just directly to surgery and then go right from there. So this is the image that I get in surgery after I remove the tumor. And you can see that there is a specimen in this picture that has a clip in it. That clip is the Savvy Scout clip that I was talking about that works by radar. So I know when I take the specimen out in the operating room that I have the right specimen. The second thing that I wanted to talk about today was the machine that we have at St. John's here. It is called the Kubtek Mozart Intraoperative Imaging System, and it involves having a self-contained X-ray machine that I can use in surgery at the time of the patient's lumpectomy. This is a huge advantage for me. Prior to having this machine, I had to send the specimen out and wait for a radiologist to take an image of it and then to tell me if yes, indeed, I do have the tumor in the specimen. I was unable to look at any margins because I didn't have that specimen or that X-ray in surgery at the same time. So this is a picture of the Kubtek Mozart machine. There is a display that you can see, and it's a self-contained X-ray machine. So as I said before, having this new machine, X-ray machine in surgery has been a huge advantage. One of the advantages is that I have the ability to not take so much normal breast tissue. Prior to having the X-ray machine in surgery, I would take extra tissue from all around the tumor to ensure that I have a clear margin, meaning that the edge of the specimen does not include any tumor cells. Now that we have the X-ray imaging in surgery, I can focus my taking more margins on exactly where it might need to be taken from. And that's a huge advantage as to not having to take a lot of extra non-tumorous breast tissue. Also, it decreases the time that the patient spends in surgery. I don't have to wait for the image to be read by a radiologist and tell me if I indeed have the specimen or the tumor or not, and it saves time for everyone. It also decreases the need to perform a second surgery. Typically, when I take margins, we wait for the pathologist over a few days to tell us if indeed our margin is clear. But with this new X-ray machine, it has definitely limited the amount of re-excisions that I'd have to do, meaning I won't have to take as many patients back to surgery for a second time. 3D imaging is great. It's amazing to see right there in surgery at the time it's being done. Now I want to show you an actual patient that I took care of a month or two ago. This is a 77-year-old woman, and she had a 9-millimeter invasive ductal carcinoma to the right breast in the upper outer quadrant. She was a fairly healthy woman with diabetes and high blood pressure. She had a family history of breast cancer. Her mother had breast cancer, and her daughter had ovarian cancer. On physical exam, when I saw her in the office, I could not feel any tumor, so I needed some sort of imaging guide to direct me to where this tumor was, because the patient really wanted a lumpectomy and not to undergo a mastectomy. So I did this surgery, and I'll show you the specimen in a minute, but basically I could focus my margins on taking just a few areas of extra tissue from the breast and not needing to take a whole lot of normal breast tissue. So this is the specimen when it's been removed from the breast. You can actually see the 2 clips in that specimen, and it's hard to make out, but maybe faintly you can see that in between the 2 clips is the area of darkness. That's the tumor. So next I want to bring you into the operating room with me. This is a patient that I did just last week, and I'm going to show you exactly how I use the Mozart imaging system. So we're going to put the mouse into the machine. I usually just do short superior, long lateral. I don't know if you can see my stitches, and I do double deep. So I put it in how it'll sit so that the highest part is right under the red dot. So we move it around a little. I'm all sterile still. And then we use our nurse to shut the door. 1 second, let me see if I can move it a little more. There we go. Okay. And then we're gonna, come over here. Can you move it this way for me? And then we're gonna use the 3D option and do what you know. And then we'll continue. And then I just want to see, like I said, if we've got the Savvy clip or not, and see where it is as far as margins, because this was not my easy case. Yeah, so we've got the clip. It's in the center of the specimen. This is just the 2D image. So lateral going to the right, superior going up, and then double deep is deep in that specimen. So now that you saw a video of what goes on exactly in the operating room, you can see how we use the Mozart and how much it's been an advantage for me. And I appreciate you listening to my talk, and I'll be around for any questions in the live session.
Thank you, Dr. Babashoff. Next, we have Dr. Lisa Brand. She's also a surgeon in Camarillo, and today she's going to be talking about surgical management of high-risk breast lesions.
Hi, my name is Dr. Lisa Brand, and I'm a general surgeon practicing out of Camarillo, California. And I wanted to talk to you a little bit today about surgical techniques in managing high-risk breast surgery. So typically you're going to come and see your surgeon when you or your primary doctor notice either a lump in your breast or you have something abnormal on your screening mammogram. Occasionally you may also notice other breast changes such as nipple discharge or inversion that'll lead you to see other specialists. So if you have an abnormality seen on your screening mammogram, these are typically very, very small things. They're microscopic, so they're hard for us to feel. So typically we're going to start with a biopsy. The biopsy could either be benign, in which case we'll continue to follow your imaging, or your biopsy is going to be concerning for something, a possible early malignancy or something that's sometimes associated with a malignancy, and then you'll see the surgeon and we'll talk about doing an excision, usually with either a Savvy Scout or wire localized, which helps us find that microscopic teeny tiny lesion. There's a picture of the Savvy Scout probe there that we use to help identify that lesion. And I think Dr. Babashoff is talking a little bit more about the details of how we use that. If the biopsy shows invasive cancer, it's still usually very small, but then we're going to recommend taking that out and also doing an axillary sentinel lymph node biopsy. And again, to take it out since it's very small, again, usually going to use a Savvy Scout or a wire to localize where that is. If you notice a small bump, a small lump or mass, again, you're usually going to start with your imaging and biopsy. Again, if it's benign, usually just following it. And then if there's something that's concerning for a possible cancer, we're going to recommend removing that with a lumpectomy, which is just removing that mass and a little bit of surrounding tissue. And if the biopsy is concerning for an invasive cancer, then you're going to get a lumpectomy with also an axillary sentinel lymph node biopsy that helps us stage the cancer for you. And so again, that's just removing the tumor and a little bit of tissue around it. And some women also prefer a mastectomy, so that's another part of the conversation. If you have an invasive cancer, I may talk about that as well. If your mass is bigger, and again, it's relative based on your breast size. So if it's a bigger mass compared to your breast size, there's no cutoff in size specifically, but just compared to your breast tissue. So if it's a bigger bump, then we're usually going to be talking more about removing it with a mastectomy. There are times we can do nipple sparing and do reconstruction. You can also talk about prophylactic contralateral mastectomy with your surgeons, and occasionally we can also talk to you about preoperative chemotherapy to try to shrink that to do just a lumpectomy instead of a complete mastectomy. Another interesting subset of patients that we've been seeing more of is patients who have a strong family history of breast or ovarian cancer, or who have tested positive for BRCA or other of the high-risk breast cancer genes. And these patients can qualify for getting a prophylactic bilateral mastectomy. I know a lot of people are aware of this after Angelina Jolie, but there are a lot of people who still don't know this is an option for them. And this can help alleviate anxiety when you know you're high risk. It can minimize your screening. And it can also have really great cosmetic outcomes with nipple sparing and immediate reconstruction. So there are some before and after pictures that I think have a really great cosmetic outcome. So again, in summary, usually you're going to come and see your surgeon if you have either a mammogram abnormality or a palpable mass. You're going to start first with your imaging and biopsy, and then discuss with the surgeon whether you qualify for either a lumpectomy or mastectomy, if you need sentinel lymph node biopsies, and then can also talk further about prophylactic mastectomy in certain patient populations. All right, thank you for letting me speak to you today.
Thanks, Dr. Brand. Next, I will be speaking to you about moving forward with plastic surgery. But suffice it to say, anything that I say today is representative of my own opinions and not necessarily of any of the organizations which I may be a part of or represent. Now, today the theme was moving forward, and chose to focus on this in a number of ways, talking about new techniques as well as some new data, some new options, as well as legislation, and finally about us as people as a whole and rebuilding our lives. So first, talking about technique, a number of newer techniques have become options more recently. Some of these things were things we have tried in the past, but we didn't quite have the technology to make them successful. One of those is prepectoral reconstruction, which is basically using implants and or your tissue expanders on top of a muscle. You can do it in 1 stage or 2 stages. It can be done with nipple sparing or skin sparing. And the idea behind that is that you should have less pain with this technique, as well as less muscle animation, which is what happens when, if you've known of anybody with implants underneath their muscles, when they flex it, that muscle moves, and some people really don't like that. There are some potential disadvantages, and that really depends on how good your mastectomy flap is over the top, as well as whether or not you need radiation. And again, some of the data is still out on some of that aspect of prepectoral reconstruction, but definitely now an option where it was a lot less of an option in the past. In fact, it was not a very good option in the past. We'll talk a little bit about why. Secondly, having 1-stage breast reconstruction. Again, it's for certain select patients, it's really great, especially if you want to stay about the same size, that you have excellent skin. Ideally, don't have any droop, which is very few of us, and having the right, quote unquote, right cancer, meaning that the cancer isn't close, and it depends on your size and how we don't want to affect how your cancer treatment is. The other disadvantage to this is you are leaving the size choice up to me intraoperatively, depending on what your tissue looks like at the time. And so you really can't adjust it as much as the traditional way, which is putting in 2 stages, which is putting in your tissue expander first as a placeholder and expanding that skin if we need to, and then changing it out for a regular implant. Next is nipple sparing. Now, this is something that our team has been doing for, gosh, quite almost a decade or more now, but it is new for some people. And that's the idea of that you can actually spare your nipple, that you can actually save your nipple, and that we don't need to reconstruct it. Now, obviously this is for select patients who actually like their nipples already. They already have good skin tone, no droop, and again, have the right cancers. And of course, you got to like where your nipples are now for the most part. Now, secondly, internal bra, which is using a dermal matrix, which is skin, not your own skin, that has been processed for its fibers, or there's now a new material out. And that can be used to sort of construct an internal bra to help support your implant. This has allowed us to open up reconstruction with implants to people who in the past we would have said was not a good option. For people who already had radiation or planning to have radiation, it allows us much more fill on top when you are in the operating room, allows us to do that one stage that we were just talking about, breast reconstruction or pre-pectoral that we were just talking about. So really this dermal matrix or this new material has been sort of a game changer. Next is delayed versus immediate. For some people, it is much better to delay for one reason or another, usually because of some sort of cancer treatment, and in conjunction with your oncologist, we decide to do that. However, we have shown that at least for radiation, there's twice as many complications in delayed reconstruction versus immediate. And so there are times where we might consider doing immediate, and most of my patients end up choosing to have the immediate reconstruction, unless I don't see them till after their mastectomy. Next, oncoplastic reconstruction. Now, most people think, well, I don't really need to see a plastic surgeon unless I'm getting a mastectomy. And that's actually not true anymore. Depending on the type of breast you have, the size that you want to be, the size of your tumor and how much is going to be taken off, it may be worthwhile to see a breast reconstruction plastic surgeon who can talk about rearranging your remaining tissue after a lumpectomy. Sometimes they'll give you immediate reduction or a lift, sort of make the same cuts we would have if you were doing it cosmetically. And why do we ask to do this? Because 20 to 30% of people have deformities after a lumpectomy, and only 44% had satisfactory results after reconstruction, after the fact and after the radiation. So if we think that there might be an issue, it's something that you want to consider doing at the same time as your lumpectomy. And this, of course, takes teamwork, which is why it's so important to have people who are willing to work on the team, like the people you're hearing from today. Of course, what surgery you have, as you can see on here, depends a lot on that tumor. It will change your skin incision, the location of your tumor matters, the size of your tumor, and whether or not you're going to have radiation. Now, next, a little bit about new options in implants and what to do about them. We know that for implants themselves, they can be saline, which is salt water. They can be silicone, or they can be what people have been calling the gummy bear silicone, which is really silicone, but it's just a little bit more linked. And so it's a little bit firmer, more like a gummy bear consistency as opposed to liquid. The shape you can be round or shaped, although more and more of us are going to smooth rounds, and I'll explain that in a minute. And then next, the surface can be textured or smooth. But again, as I said, for reasons we're going to speak of on our next slide, most of us have gone to smooth surface for both our tissue expanders as well as our implants. Sizes come in different shapes, different sizes and widths, of course, different volumes, and then different projections. And those all can be tailored to you, which gives us a lot more options than we have in the past. And then finally, tissue expanders, which are, if you're doing the two-stage reconstruction, we first put in the tissue expanders as placeholders, and then they're switched out to the implants that you want after the fact. Sometimes the tissue expanders are placeholders, so they can be switched out to your own tissues later in the fact. Because of the new information, which we'll talk about in the next slide, most of us, like I said, have gone to smooth, and now there are tissue expanders that are smooth that I've been using ever since they've come out. So talking about moving forward with data, there is a BIA-ALCL, which you might have heard about in the news, which is a type of lymphoma that can develop around breast implants. The statistics so far have shown that on average, it comes out about 8 years after your implants, although the range can be 2 to 28 years. As of January 2021, there have been 355 total confirmed cases in the entire history of the implants, and unfortunately 36 deaths. They think that your chance of getting it with an implant is 1 to
2,200 to 1 to 86,000. And the reason we don't know that is we're continuing to gather data now. Of course, that is in the face of having approximately 10 million patients with implants in the United States at this time. There was an FDA hearing back in March of 2019, which actually I was an invited speaker to, and we talked about the safety of breast implants because it's so important to us as plastic surgeons and myself, who is a breast cancer survivor, who also has implants in, that these implants are safe. And so the most important thing about this is to know that it can occur. And the most important thing is that the early diagnosis is important. So if you notice that you have one breast that suddenly swells, or there's fluid on one side, or breast mass that you haven't noticed before, you want to make sure that you're seen by your oncologist, your breast surgeon, and or your plastic surgeon, so that they can do the correct workup and catch this early. If caught early, it is treatable, but unfortunately, if caught later, it can be aggressive, and as you can see, can lead to death. So it's important that people are aware of this. It is more likely to happen in textured implants, which is why, as you saw after the FDA hearing 2019, there was a recall for the Allergan BioCell, which accounted for more than half of the cases in the United States. Next, moving forward with legislation, I always end or at least include this in part of my talk every time in the last 12 years, because I think we can't say it enough. Back in 1998, the Women's Health and Cancer Rights Act was passed. I'm happy to say I was a part of that passage. And what it says basically is that insurance must cover breast reconstruction after a mastectomy. And that includes the balancing procedure on the other side to help make them match. It includes breast prosthesis in the process of your reconstruction, or if you choose to never have breast reconstruction. And it also includes physical complications like lymphedema, which is a swelling of one arm or the other from the mastectomy. In addition to that, back in 2015, we also passed the Breast Cancer Patient Education Act, because believe it or not, after all those years, many women still tell us that they didn't know that they had the right to have this covered by insurance. I mean, it's sad that it took till 1998, but even sadder that all those years people still didn't know. So we asked the Health and Human Services to have an educational campaign to let patients know that there is insurance coverage that includes all of the above. So there are also state laws that mandate that women who get mastectomies are offered a consultation with a plastic surgeon before their mastectomy. It's unfortunate that 7 in 10 women are not told about their options before their mastectomy. We really are trying to change that. In fact, our center, the Integrated Breast Center, is part of the National Accreditation Program for Breast Centers. And one of the requirements is that all mastectomy patients have to be offered a plastic surgery consult to a board certified plastic surgeon. And so that is progress, but it's still not enough. And we're continuing to work on that. So speaking of accreditation, I talked a little bit about our breast center, and I really wanted to show that, later on in 2020 will be our 10th anniversary of our ribbon cutting of our Integrated Breast Center. I'm so proud of it. Only 53 sites in California are actually accredited by the National Accreditation Program in breast centers. So we're very proud of having that. We do have a center in Suite 380 and the Oxnard campus. And then in Camarillo, we opened a cancer resource center. Unfortunately, it opened in February of 2020. So you know what happened then, COVID shut it down, but we're happy to say it is open again. And things that are being offered are support groups, including for caregivers and for children, social work, nutrition counseling, resources, wigs, rehabilitation, relaxation therapy, yoga, tumor board, breast conferences. We meet twice a month just about breast cancer and our patients, and reviewing what the treatment goals are with an entire group of people sitting around the table, different specialties, just to make sure you get the best care possible. And then of course, we have our most wonderful Alicia Zaragoza, who's our nurse practitioner and our nurse navigator for the program. If you haven't met her already, you should. She is a great asset to our program. And I say this because I want people to know how important it is to have a team that's there for you and part of your care. I know personally as a recent breast cancer survivor, that this team was critical to me, and I could appreciate from the other side and realizing how important it is for our patients that they know we work together and that we are there for you, not just about treating your disease, but about taking care of you as a whole person. And that's really about moving forward and rebuilding not only our program together, but rebuilding all of us together.
Next, we're very excited that we have a pathologist for the first time in our 12 years, and that is Dr. Tony Migler, and he will be giving us a primer on Pathology 101.
Hi, my name's Anthony Migler, and I'm one of the pathologists here at St. John's Hospital. And this morning we're going to be going over basic pathology. And so we thought we would start with a brief sketch of anatomy and histology. So anatomy is what we see grossly with our eyes. And what we see grossly with our eyes is the breast. And then attached up here is the arm. And in this area here is something called the axilla. And the axilla is where the lymph nodes are. So we get a good deal of information about the state of the breast from the lymph nodes that are in the axilla. Now, when we see a lymph node grossly with our eyes, it looks something like that, not quite that big, about the size of a bean. We take that and we cut it, and I'll show you in a moment. We'll be showing you in a moment how we process those. And we look at those under the microscope. And when we see them under the microscope, they're composed of thousands of lymphocytes. The same cells that you see in your peripheral blood when you took biology in high school, that's what makes up the lymph node. Now, when we're looking at the breast itself, the breast is composed of lobules. So the lobule is the basic unit of the breast, and the breast contains many lobules, probably 20 to 30 lobules, and the lobules are composed of glands, and they're contained in this entity we call the lobule, and the lobules are each connected to each other and to the nipple by ducts that drain to the nipple. During lactation, these glands make milk, and these glands, if we take a lobule and expand it, we will see glands all together, and these are called breast glands. And the gland itself is composed, the lobule itself is composed of many glands, and the glands have these collections of cells which are glands, and the glands have cells, and the cells have nuclei. So lobule goes to gland, and then the gland is made up of cells, and that's what we're looking at when we look under the microscope. And when a biopsy is obtained, it comes to us in the laboratory, and it has to be prepared before we can look at it under the microscope. So our next little quick session is going to be the laboratory. Working in the laboratory, what we do with the biopsy after we receive it from the physician is we compare it to the order, and there'll be a name on the biopsy. We make sure the two are exact. Then we process the tissue in a tissue processor. It goes through various fixatives, formalin and xylene and alcohol. And then our histologist, Lisa, will take the finished product in the morning and embed it in wax and cut the wax block and make slides. The slides are stained, and then at that point they're given to the pathologist along with the patient's name and the patient's requisition form, and then we look at it under the microscope. When the pathologist receives the slide at the microscope, we put it under the ocular, we look at the tissue, and we often make pictures and show each other, and diagnose the histology that we're looking at that point. Here are the examples of the slides we're looking at. The first one is normal breast tissue. The second one is abnormal breast tissue. And the third one is from a lymph node that is taken for prognosis. So if you have any questions or comments, please feel free to email me through the St. John's Regional Cancer Center, and we will get back to you. And thank you for your attention. Have a good rest of the day.
Thank you, Dr. Migler. That was fascinating. Now next we have Dr. Henry Montes, who will be talking to us about innovations in radiation oncology.
Hello, my name is Dr. Henry Montes. I'm a radiation oncologist and a member of the oncology team servicing Ventura County at both St. John's hospitals. I would like to show you our radiation facility at St. John's Hospital, where installed is some innovative equipment that precisely delivers radiation to my patients. In our treatment room, we have a variant linear accelerator with a BrainLab ExactTrack dynamic tracking system that is coupled to our treatment planning computer system and allows me to safely deliver radiation therapy to at-risk tissue, either with curative intent or to complement additional therapies that are ongoing during a patient's treatment protocol. Later in my talk, I will speak more about the specific technology. However, I will be introducing briefly the history of radiation therapy, its role in the treatment of breast cancer, and the evolution of technology leading to our therapeutic options today. Radiation therapy is one of the oldest technologies that has been studied for greater than 100 years. With the advent of the discovery of the X-ray by Roentgen in 1897, followed by Marie Curie's discovery and the science of radium in 1898, this energy source was quickly identified as a therapeutic option for several ailments of the day. In fact, the first documented curative use of radiation was for basal cell skin cancer in 1899. The clinical experience of radiation therapy as well as the technology evolved over the following decades, with a significant milestone announced in 1950 by Dr. Vera Peters declaring the cure of Hodgkin's lymphoma that was then known to be a fatal diagnosis. Cobalt radiation evolved in 1951, and the first linear accelerator similar to the technology used today followed shortly thereafter. Depicted on the left of this slide is the energy spectrum, revealing that X-rays and gamma rays are along the same energy spectrum as radio waves and light. It has been learned that radiation's effects on a cancer cell, in fact, is at the critical level of cell reproduction, specifically that of the DNA. Radiation has an indirect effect on DNA, thereby rendering a cell's inability to replicate, and in essence leading to its eventual death. Depicted on the lower central portion of the slide is a rendering of the potential systemic effect radiation may have in stimulating an immunogenic response that has long been suspected and more recently has been exploited with our more sophisticated high-dose methods of radiation delivery. Why is radiation therapy utilized in breast cancer? This slide demonstrates in graph form the outcome of radiotherapy with respect to local control of the breast following breast conservation surgery, or what we know as lumpectomy. The graph on the left reveals the benefit of radiotherapy following lumpectomy in controlling the growth of breast cancer within the breast. These results correspond to the maturity of this data measured or extending greater than 10 years. This is a study of greater than 6,000 women that reveal that in the absence of supplemental treatment with radiation to the breast following lumpectomy, there is about a 1 in 3 chance of local persistence or regrowth of breast cancer cells within the breast itself. This is reduced down to about 1 in 10 chance when radiation is offered. The graph on the right, in fact, shows a modest improvement in survival when radiation is offered to the breast following a margin-negative lumpectomy. This is one of many studies that have documented the benefit of complementary or adjuvant radiotherapy following a margin-negative lumpectomy. So when is radiation utilized in breast cancer? Adjuvant therapy or complementary radiation is a term used when a treatment is offered to improve the odds or in fact reduce the risk of a cancer persisting following a primary or curative treatment. In the case of breast cancer, this is surgery. Adjuvant radiation therapy is offered for high-risk characteristics following mastectomy to aid in control of the chest, and following a margin-negative lumpectomy offered with the goal of reducing local persistence in the breast. The types of radiation therapy include external beam radiation techniques with names such as intensity modulated radiation therapy or IMRT, tomotherapy, cyberknife, and proton therapy. Internal methods of radiation delivery are technically called brachytherapy, where the radiation source is positioned within the tissue at risk. Similarly, radiation can be delivered at the time of surgery. Depicted on this slide are images of the varied radiation external beam techniques. All of these modalities result in similar outcomes and all are computer-driven, allowing the precision of radiation delivery. With these technologies, the radiation profile can be sculpted to precisely deliver radiation to the at-risk tissue and spare the adjacent normal tissue. This slide demonstrates the ability to overcome the previous limitations of uniform dose distribution within the breast tissue itself. And these images reveal the ability to sculpt a high dose of radiation to the intact breast as depicted on the upper right image, and the regional lymph nodes as depicted on the lower right image, sparing the adjacent underlying heart and lung tissue. Treating part of the breast often utilizes brachytherapy or intraoperative techniques as depicted on this slide. The upper left image reveals a balloon catheter that is positioned within the breast at the time of surgery and allows the delivery of radiation within this catheter shortly thereafter. The image on the upper right is an interstitial brachytherapy technique which places several catheters within the breast tissue corresponding to the previously located tumor site. Radiation sources are positioned within these catheters and allow radiation to be delivered precisely and safely to the localized tumor bed as depicted in the upper center image. Similarly, positioning a source within the breast at the time of surgery and delivering radiation during that surgical procedure is another technique currently in evolution and allows the delivery of radiation to the resected tumor bed. This is a pictorial of our Varian accelerator and the BrainLab ExactTrack system demonstrating in the upper left image the localizing beams that ensure the exact positioning of the patient and the exact position of the at-risk tissue to be treated. And on the image to the right, the precise delivery of radiation to that site immediately thereafter. This technology allows me to safely deliver radiation very precisely and is often now used as curative or ablative treatment to isolated localized tumors of the lung. These precise modalities of radiation are often now utilized throughout the body to include sites such as the brain and isolated skeletal or bony abnormality. This is known as stereotactic body radiotherapy or SBRT. This last slide is a short video revealing the innovative and sophistication of our current radiation technology that includes an innovative smart treatment table that moves in correspondence to the required positioning of the patient. Thank you for your attention. There will be a live question and answer session following our presentations. Should you wish any further information, please submit via chat.
Thank you, Dr. Montes. You always have such interesting talks. And next we have Dr. Fred Mortazavi, an oncologist, who will be talking about new advances in the last year.
The theme of this year's symposium is the moving forward. So I'm presenting the relevant clinical information in the field of breast cancer that were published in the past 12 months. The first study I would like to present and draw your attention to is a population-based study regarding the genes that were have been associated with increased risk of breast cancer. In this published study in New England Journal of Medicine, the investigators reviewed a cohort of population-based studies that they were called CARIES, composed of 17 case control studies that reviewed the incidence of basically cancer predisposing genes and their association with breast cancer. This is a very important note and basically subject, because based on the likelihood of developing breast cancer in normal subjects, a lot of patients decide to proceed with prophylactic surgeries, including mastectomy or oophorectomy. In this case control study, there were almost 32,000 patients with breast cancer as cases and 32,000 healthy individuals as controls. And the incidence of these genes in the population were estimated to be around 7 to 10%, but these patients were mainly, these incidents were mainly detected in patients who had family history of breast cancer or had breast cancer themselves. And the true incidence of these cancer-causing genes were unknown in the US population. In this slide, you can see the composition of the two groups. the cases and controls in terms of age and ethnic background, and these are the basic composition of different studies that aggregated together to get this data. Results of the study showed that the incidence of these pathogenic variants or genes associated with cancer development was about 5% in patients who had breast cancer, as opposed to only 1.6% in control population or healthy individuals. When they calculate the risk of breast cancer development or risk of breast cancer in general in folks who had this mutation versus relative to healthy individuals, the highest ratio, the highest odds ratio was seen in patients with BRCA1 and BRCA2 mutations with an odds ratio of 7.6 and 5.2 respectively. The next high incident, the high ratio was seen in the folks who had PALB2 mutation. The rest of the incidence of breast cancer in the rest of these genes was much lower. For example, in ATM was 1.8, in CHEK2 was 2.5, in RAD51C and RAD51D only 1.2 and 1.7. The rest of the pathogenic variants, for example, RAD1, RAD51C, RAD51D, were seen mostly in estrogen receptor negative or triple negative breast cancer, and the other famous ones are ATM, CDH1, or CHEK2, were seen in estrogen receptor positive breast cancers. So I think this is an important point to know of quantifying the risk of developing breast cancer if somebody decides to do prophylactic surgeries, especially in a young age. The next study that I would like to share with you is using olaparib, which is a PARP2 inhibitor, and is routinely used in patients who have BRCA1 or BRCA2 mutations in the metastatic setting. And using this particular drug in adjuvant setting, meaning after surgery, using these drugs to reduce the risk of cancer recurrence. So in this study, they randomized a true group of patients who had BRCA1 or BRCA2 germline mutation after they received their surgery, and if they're high risk to the point that they required systemic chemotherapy, they randomized them in 1-to-1 ratio into either receiving olaparib or placebo. So this slide shows patient characteristics. 921 patients in the group who received olaparib and 915 in the patient in the control arm. And this slide shows the result of the study. There was an improvement in disease-free survival. However, improvement in overall survival, although statistically significant, but it was marginal. The next study is using an interesting drug immunoconjugate and antibody combined with a cytotoxic chemotherapy for treatment of triple negative breast cancers. This is particularly important because triple negative breast cancer are notorious for having pretty much no options other than systemic chemo and more recently immunotherapy. So the new drug, which is an antibody against TORP2 combined with an topoisomerase inhibitor, which is a potent chemotherapy agent, was used against the triple negative breast cancer. So this new antibody drug conjugate is called sactuzumab, and I'm going to skip over the patient demographics and show you the overall survival and disease-free survival slide. The top line shows the patients who received sactuzumab, almost 235 patients, and the control arm, which was chemotherapy, alone. It was investigator's choice. 233 patients, and there's a significant difference between the two. And in this side of the slide, you can see the difference in overall survival between the two groups. The last study I would like to present here is this study published in July of this year that discusses the duration of hormonal blocker therapy, aromatase inhibitor therapy for patients who have estrogen receptor positive breast cancer and or postmenopausal. This has been a controversial topic, and in previous studies in younger patients, it was shown that 10 years treatment with aromatase inhibitors was superior to only 5 years and provided less disease recurrence. However, there's always a downside to these longer treatments, which here is particularly risk of osteoporosis and fractures. So here was a phase 3 randomized trial that randomized the patients to two groups. First group who was on aromatase inhibitors continued after the first 5 years, continued additional 5 years to complete a 10-year course, and the second group after the first 5 years of aromatase inhibitors only received 2 extra years to finish a 7-year course. This slide shows the composition of the two groups. They had 1,600 patients in the group that received additional 2 years, total 7 years, and almost 1,600 patients in the group that received 10 years, additional 5 years of hormone block. So in this slide shows the disease-free survival and overall survival curves between for the two groups that received a total of 10 years versus the group that received total of 7 years. And you see there is no difference either in disease-free survival or overall survival. But if you look at the side effects, which is mainly bone fractures and severe osteoporosis, in the group that received 10 years of aromatase inhibitor versus group that received 7 years of aromatase inhibitor, there's a big difference in incidence of bone fractures. Therefore, we can conclude that for postmenopausal women who has been receiving adjuvant hormonal blockers with aromatase inhibitor, the 7-year course will be adequate, and you should not basically increase the risk of fractures for this group of patients. So with this, I would like to thank you for your attention, and I hope you enjoy the rest of the symposium.
Thank you, Dr. Mortazavi. That's so interesting. And finally, we have Susan Speer. For any of you who are returning, you know that she's one of our favorites. She is one of our board-certified nutritionists, one of 5 that are certified in oncology in the state, and we're happy to have her as part of our program. Today, she's going to be talking about Wellness Reset.
So here we are back after a year at the 12th Annual Breast Cancer Symposium, and I'm so glad you all have come to join us. Things are better this year than they were last year. Maybe not quite as better as we were hoping they were going to be, but things are opening up. Some of us have even gotten out of our pajamas and gone back to our offices or returned to some of our usual pre-pandemic routines. But it's occurred to me that maybe we shouldn't return to our usual pre-pandemic routines in every case, that we have an opportunity right now to reset our health habits, our thinking, and maybe our commitment to self-care. Some of our old bad habits may have been abandoned when we changed everything last March. Some of us may have found some time during the lockdown to start some new positive self-care habits. Some of us might have gone the opposite direction with the stress of the pandemic. So let's take stock and evaluate our wellness with these 4 questions. How much do you weigh? And as a corollary, how does that compare with what you weighed before the pandemic? Where do you stand with physical activity? Or are you just sitting? How healthy is your diet, and how are you doing with coping with stress? So wellness check number 1, evaluate your weight. Jump on that scale. I hate to say that to a room full of women where our body weight sometimes carries a lot of emotional baggage with it, but our body weight is probably the most important risk factor for postmenopausal breast cancer, which encompasses 80% or so of total breast cancers, a risk factor that we can change. And many of us gain 1 or 2 pounds a year as we age, and so by the time we hit 50, that's quite a bit of risk. This year, a big study reported pooling together the results for over 1 million women, showing that what we already knew is that being obese increases your risk of postmenopausal breast cancer by 40 to 50%. This study also showed that the risk begins to rise even when you're overweight. So that's the bad news. But here's the good news. It's never too late to do something about it. Another study that reported recently showed that even modest weight loss, even just 4.5 to 10 pounds of weight loss in our adulthood, drops that risk, reverses that risk of breast cancer by about 18%. And if you lose more weight, 20 pounds, it reverses the risk by even more, a third. Even women who lost weight in the first 5-year period and didn't maintain it in the second 4-year period, gained a little back, they still had reduced risk of breast cancer. What if you've already had breast cancer? Does weight loss decrease your risk of recurrence? The answer is we don't have a lot of study where that's concerned, but in the Women's Interventional Nutrition study, it seemed that modest weight loss, like 3, 5, 6 pounds, might also decrease the risk of recurrence. If you wanted to throw something at the computer when I ask you to jump on the scale and check your weight, here's another good news. Study after study have shown that women who are more physically active have reduced risk of cancers, both postmenopausal and premenopausal, and that's true for women no matter what their weight is. Women who exercise have less breast cancer. Even women who have already had breast cancer, we see that women who exercise have a 30% reduction in recurrence. So modest exercise, just 150 minutes a week, so that's a 30-minute walk on 5 days, reduces your risk of getting breast cancer in the first place, maybe 10 to 20%. A little bit more physical activity is needed in order to reduce your risk of recurrence and improve overall survival. In one recent study that looked at women who were done treatment with breast cancer and taking the hormone blocker letrozole, in a randomized controlled trial, the exercise arm reported that they had better quality of life, felt less fatigued, and had less side effects from the medicine. How much did they exercise? 150 minutes a week plus 2 30-minute strength training exercise. Now, if you're thinking that you can exercise in order to lose the weight, think again. Don't count on it. Exercise is not very useful for weight loss because your fork is faster than your feet. So my third wellness check is how healthy is your diet? And the test I want you to do is write down everything you eat for a week. Now, I know some of you just rolled your eyes because nobody wants to write down everything they eat for a week, everything you eat and drink. But after asking probably 15,000 people in my whole career what they ate yesterday, I can tell you most people can't remember what they ate yesterday. Never mind wrap their mind around what they ate for a week or get an accurate picture of what their trend is over a couple of weeks. So put on your scientist hat and actually find out what you really eat. If you need to lose weight, you might consider tracking on one of the free tracking apps like MyFitnessPal or Lose It so that you can see what's happening with your diet, because tracking and then making changes to stay in calorie budget is one of the most effective ways to lose weight. It's simple and it's free if you use one of these free apps. And while you're at it, why don't you track how much exercise you're getting too? Are you really getting those 4 walks a week that you think you're getting? Then, after you've got a week worth of food diary, take a look at your diet and see how does it stack up. Everything that's on this slide are things that are associated with breast cancer risk. The top of the foods are generally associated with protection, the bottom with increased risk of breast cancer. So for instance, take a look and see, are you getting 5 cups of fruits and vegetables every day? Because women who get 5 cups every day have less breast cancer risk than women who get only 2.5. And that's even stronger for women with estrogen receptor negative breast cancer. Some fruits and vegetables are even more powerful with protecting you from breast cancer, like the cabbage family and the carotene group of vegetables. dark green leafies, orange like sweet potatoes and carrots. And that has been supported by some studies that have reported recently that show that women that have higher levels of carotene in their blood have less breast cancer risk. And even this year, a study reported that looked at women who are at high risk for breast cancer because of genetic background, family background, or dense breast, finding that women had higher levels of blood carotenes had less breast cancer risk. Now, blood carotenes are a marker for fruit and vegetable intake, so it may be something in fruits and vegetables that protects against breast cancer. So don't run out and buy beta-carotene pills. For one thing, beta-carotene pills increases the risk of lung cancer in people who are at high risk for lung cancer, like smokers. And in the past couple of years, we've had a couple of studies that have looked at women taking supplements through treatment and finding that it might decrease their overall survival if they took some supplements during treatment, mostly the antioxidant supplements A, C, E, but in one study, even multivitamins. If that was you, don't panic, because I think these are weak studies. They had to do a lot of statistical manipulation to make them significant, and they don't all go in the same direction. But maybe it does give support to the fact that we shouldn't be taking high-dose supplements during chemotherapy or radiation. This year, on the other hand, a review and meta-analysis reported that women after breast cancer treatment who took supplements C and E and multivitamins had less recurrence. So take a look. How many fruits and vegetables are you eating? What about alcohol? Did you start drinking during the pandemic? 4 drinks a week increases your risk of breast cancer and maybe increases your risk of recurrence. What about junk food? Because we know inflammatory diets increase your risk of breast cancer and your risk of recurrence. And finally, even though all over the internet you read sugar feeds cancer, we really haven't had very many studies that have shown us that. But just last year, at the end of last year, the NutriSanté study reported with about 90,000 French women showing that women who ate 10 teaspoons of sugar or more had about a 52% risk, higher risk of breast cancer than women who ate 4 teaspoons. So take a look at those aspects of your diet and choose 1 or 2 that you think you might go forward with by resetting your wellness goals. Now, my 4th question is, how are you doing with stress management? Nobody would put stressful life events or stress management at the top of the list as an independent risk factor for breast cancer. But we do know that women who rate themselves as coping well with stress do better with achieving other healthy behaviors that do have an impact for breast cancer, like not smoking, not drinking, eating a better diet, exercising, being able to keep up with their health maintenance schedules, like getting their mammograms on time. And then we know that women who've had breast cancer who rate themselves as not coping well with stress tend to report more pain, more trouble sleeping, more fatigue, and lower quality of life. So ask yourself, how am I doing with anxiety or depression? How's my mood? Am I angrier or sadder than I used to be before the pandemic? Even if you don't think you're distressed, I encourage you to take the time to do a little self-care, to do a little self-love by engaging in my favorite stress management activity, which is the proven antidote to distress, and that's happiness. Now, I can just hear you all saying, well, duh, Susan, if I was happy, I wouldn't be distressed. I can't just turn it on and off with a light switch. And I'm here to tell you that you almost can. In some of the studies done by a researcher, Sonia Lubomirsky, looking at how to raise your sense of happiness, what she found is the most powerful thing that increased your sense of happiness, that increased your happiness quotient, was talking to yourself about what you're grateful about. So list to yourself at least 3 things that you're grateful for. Could be simple. It could be just that you didn't break your shoelace this morning when you tied your shoe, or that your car started, or that you had a wonderful talk with your daughter last night. That's one of my things that I'm grateful for. So talk to yourself about what you're grateful for. It only takes a few seconds. You can do it every day. And if you want to even increase your sense of happiness even more, tell somebody else about what you're grateful for. So now's the time to maybe reset our wellness, to look at how you're doing, to evaluate how you're doing by asking yourself those 4 questions. Look at weight, exercise, diet, and stress management. Pick out 1 or 2 things that you're going to change that's going to improve your risk of breast cancer or decrease your risk of recurrence. And don't forget to always include counting your blessings.